Planetary Health First, Mars Next. My name is Michael Mann. I'm the host, and today we have Dr. Gupta, and I am super excited because over these 90 days, I'm going to be diving really as much and deep as I can with mental health, behavioral health, and of that is the preventable epidemic with opiates. We have so many, about 100,000 lives and growing exponentially, sadly, that are dying, that are preventable in the United States. So Dr. Gupta, I'm so glad you're here. Just quickly introduce yourself before we get going.
Yeah, I've been a primary care physician in a rural community, non-educational setting since 1986. I was practicing in my office, hospital, and nursing home, taking care of my patients. In addition to that, I was appointed a deputy medical examiner for 8 years, where we investigated accidental deaths. I was a jail physician for 13 years, and I also worked in the emergency room part-time for about a decade. In 2006, I started learning addiction medicine because I was bothered by the fact that too many young people are getting addicted and dying from it. At the same time, I became a member of the Rotary International Club. So in 2017, I was asked a question by one of my friends. She since has passed away. We played tennis together. She was 87 now. And she said, "Doc, when is all this going to end?" And I said, "When everybody dies." I didn't have a good answer. And she gave me a dirty look, and I knew I had to do something. So I started researching what are the problems I face and the patients face. Ended up writing a book that's called The Preventable Epidemic, and a frontline doctor's experience and recommendations how to resolve it. I've done more than 1,000 presentations, one in large groups, but it's not improving.
Mm-hmm.
Thank you for having me here.
Yeah, well, thank you for being here. And it's fascinating because, like, right as I started, and I hope the feedback isn't coming through. I'm hearing a little feedback, but when I was it's just of recent that actually about a week or two ago that I said, you know what, I really am hearing information out there from others, just how bad the situation is in America with the addiction crisis, the deaths that are unnecessary. And I really want to deep dive into this. And all of a sudden you just came in my inbox. It was like that angel out of nowhere. And I was like, gosh, this guy's really chewing on this stuff. So you want to just start with the problem? And I know you can't do that in like 1 minute, but just as best as you can. I mean, I've seen the opiate movie with the Sacklers, that kind of, in Western. Yeah, which was really, I thought was pretty helpful to see one aspect of it. I know there's some other nuances, but I'll stop and just let you kind of give our audience a backdrop.
So there are two organizations at a national level. One is called Substance Abuse Mental Health Services, and the second is called American Society of Addiction Medicine. The Substance Abuse Mental Health deal with the psych portion, ASM works with the addiction portion. They both say, as of now, this year, 49 million people in America are at risk of polysubstance abuse. We're not talking just pills. We're not talking just alcohol or smoking or marijuana. These people are doing 4 to 8, 9 products a day. Of that, only 46 million people have no access to care. Only 2.4 million have access to care. That means 6% of all the addicted patients have access to care. Last year, 114,000 died. With COVID, the death rate went up 30 to 40%, while less than 7,000 providers actively provide care to patients with addiction. Even though 150,000 providers had the credentials, only less than 7,000 do it. So there were two things the government was hoping lately in the last 2 years. They passed an act called MATE, Medication Treatment Expansion Act, that went in effect June of last year, that expected any doctor could write without any training the medicine for addiction, and there was no uptake. There is no statistically significant increase in doctors providing care. The second hope they had was telehealth would improve access to care for addiction patients. It did not bring in new patients. The existing patients that were under my care and other doctors' cares, they are using telehealth. So all the efforts that have been done in the last 15, 20, 30 years are not working, and that is the reason the death rates are going up.
And then failed cities, right? I mean, you see, like I don't want to let's just say San Francisco, it's just like this open, those streets that are just like apocalyptic. I mean, it seems like there's something needs to be done when people are openly just killing themselves. I don't know.
Well, so it has several aspects. I visited with my family Africa in 2007, and outside of Johannesburg, they had a gated community where they had built sheds, fixed sheds, like 15 by 18 type thing, which had a bed, a bathroom, everything they need, and they put all the addicted patients live there in a dignified way. It was like 2 miles by 2 mile area, thousands of things. So why can't we do that in America? That's one aspect of it. The other aspect of it is, like COVID happened, there is nobody knew what it is. People are dying in millions. So addiction medicine is not being taught in the American medical schools, except lately in the last couple of years, they're trying to train 100 doctors per year. We need 200,000 doctors. So if the doctors are not trained, all they could do it is when somebody comes to the emergency room with overdose or withdrawal, they can stabilize and send them home. There is no treatment. I used to be a medical director in 1987 to 88 in a small community hospital running a 20-bed medical addiction treatment place. But there was no treatment for addiction. So we will take care of all the complications we've had. People had surgeries, IV antibiotics, whatever needed to be done. We gave them IV pain medications, and then they went out and did their heroin again. So it was like a revolving door. So the system is failed in so many different places. So I think the other things that we could talk about is the CDC has said addiction is a preventable and treatable condition like any other medical condition. It needs a long-term treatment. And people who are waitlisted for treatment have a very high mortality. And so if 94% people have no access to care, they're the ones who are dying. I have 85% success rate in my office. They're working people like you and me. They get back to school, they get back to work, they get back with families, they buy houses, they buy cars, they go on vacations, they come and show me the wallet and say, Doc, see, I have money in my pocket. I never had it before. I have bank balance. And they're paying taxes. And they're the nicest human beings. So we need to bring these people back into life.
So you have over a certain amount of time, you're saying you have a pretty much like a 87% success rate with your population. Is that what I'm hearing?
85% people are doing very well. They're stable. Wow. They don't relapse. They don't die. They don't need Narcan. They don't go to the emergency room for any complications. The only problem they feel is a lot of stigma. So when they go to the pharmacy, pick up their medicine, if they have to go to see another doctor, somebody needs a hip surgery or whatever, as soon as the doctor sees the medicine Suboxone, buprenorphine, they just label them as addicts, and they're really not treated nicely. So stigma is a big problem.
So do you want to share just a little bit while we're here, your sort of, I know it's every patient specific, but just sort of your regimen or your treatment, kind of like that process, if you could, just a little bit about that.
Yeah. So there is no cookie cutter thing. Like if you have sugar, high blood pressure, your medicines 1, 2, 3, 4, you do it. This is a psychological, mental addiction problem. So the two mental issues and addiction issues, and then they have got into a lot of other complications. Hepatitis B, hepatitis C, HIV, they have low testosterone, they have, sugar problem, they have infection, cellulitis. So in the first visit, I do a very comprehensive history. I take care of the medical issues. I make an assessment of the psych issues, and then I do an addiction issue. So then we have to order a bunch of blood tests, including for sexually transmitted diseases, do a urine drug test and send it out, check the state records for who is been giving, where were they getting all the stuff from. then in that visit, after I make my psych assessment, I tell them you're going to need some kind of medication to slow your brain down, help you sleep, or if you're oversleeping, I write non-addictive drugs. So when they come back after the blood test and all the reports come back in a few days or next week, they already started to feel some better. And then whatever we find else is wrong, then we start treating those conditions. And in the third visit, we start treating their addiction. Because there's so much regulations in addiction field, it is very difficult to write addiction medicine the first time, nearly impossible. So that is the protocol in general that I use, and I find it very successful. I spend a lot of time, and they like it because I sit down and listen and pay attention to their needs.
And how about you as your practice, like your panel? How many patients are you able to follow?
So, like I said, the doctors were not being trained in addiction. In the year 1999, CDC for the very first time reported that 16,000 people have died of poisoning. 106th Congress studied that problem for a year and a half, and a law was passed called Data 2000. It allowed any practicing doctor take a course, pass an exam, apply for an X waiver, and then they were qualified as addiction providers. That's how I started learning in 2006. So the law states in the first year, after you do all these steps, you are allowed 30 patients per month for the first year, expandable to 100 thereafter. Okay? And that law stayed like that until 2016. And the crisis took a hit in 2016. Several meetings happened in Washington, and they said, we can let doctors take 275 patients, but they put more restrictions, use the EMR, this, that stuff, 7 different conditions. Currently, 4,300 doctors in this country have a limit of 275. I'm one of them. My son is a board certified addiction doctor, and he has currently 0 patients. So people have credentials, but they don't practice addiction medicine because there is no incentive, and the government has put a lot of disincentives. So in that Data 2000, the language has 2 very important pieces of information. It says no other medications have such restrictions, including the prescription drugs people get addicted to or die from. So the government was forced to put this medicine because OxyContin was killing people, and the government didn't do anything. And it says, like many well-intended laws, the unintended consequences of this law is very significant. So to me, that was the first step towards the criminalization of the treatment of. OxyContin started coming out in 1995, and the federal government did a report in 2003. It's called Government Accountability Office. I don't know, most people have not heard this. I have a whole report on Purdue Pharmaceutical. And I think we need to ask the government to answer a few questions. What are they doing with this death rate going up? Why can't we have fentanyl as a class 1 drug, the street fentanyl, because the prescription fentanyl is class 2? And why did they criminalize the treatment arm, and why did they not criminalize the OxyContins? Why did they not put a diversion control plan on that thing?
Are you able to be involved, or others like yourself? Is there committees that are trying to create a better path of decision making? It sounds like these, regulators or legislators aren't the experts, and they're just going ahead and putting something in place that's just too quick. They've capped you at 275. Then you have your son that you're saying is at 0. And I imagine if he's trying to run a practice, we already know primary care doctors and doctors in general are already having enough trouble taking care of chronic disease and all, just patients in general. So it seems like you got a lot of burden on you, and how and why this came about seems like there needs to be a revamping and and what you're doing right now with writing your book. So where are we right now, and what are you doing, and other organizations that you're aligning with to try to help make meaningful, smart change or incremental, whatever it be, to try to help be involved in this?
Well, so it took me 5 years to finish my book, and I felt bad that it took so long because I was hopeful things would change after my book comes out. Uh, and unfortunately, it's been out for 2.5 years, and the death rates are going up, and nothing is helping people. More people are dying. So even though I'm talking to a lot of people, I tried to reach Washington a couple of years ago. It was very expensive and laborious. I tried to reach my state legislators, the local policymakers. They keep on funding the failed policies, the war on drug. So I wrote a paper last year that America needs a strategic change in looking at the policy, how to handle this opioid crisis. I had a discussion with O'Neill Institute a couple of years ago on the fentanyl issue. And I said, we need to make this a street fentanyl as a class 1 drug. And they said, it's all hoax. It's not going to work. I said, then tell me what's going to work. And then they don't respond to that. So there is no will and desire and information how to fix it. There is a principle called Shirky's principle. Most people have not heard it, and I'll explain it to you. It says, if there is a problem that has a solution, the institutions are not interested in fixing the problem. Once the problem is fixed, there is no business left. People have been telling me there's big business in pharma in this addiction world, and I could not figure out for a long time what that big business is. So I'm going to tell you the sad business portion. If an addicted patient overdoses or is in bad withdrawal, they go to the emergency room. It costs the insurance $20,000, $30,000. If they have no insurance, it costs the taxpayers that kind of money because hospital has to recover somewhere. Now, the same person dies at a young age of 20, 30, 15, 40, whatever. They have a functional brain, heart, liver, kidneys. Each organ is harvested at $500,000. So I spoke in Boston at a physicians meeting in 2016, and I did my that time kind of old presentation on addiction, not the one I do now, because mine is changing. And after me, there was a transplant surgeon who spoke, and he says, business is very good. We running the operating table 24/7, 2-3 shifts every day. So after this presentation, I said, what's going on? He says, we're getting too many organs. I said, where are you getting the organs from? He says, all the young people dying, their organs are harvestable. So before this opioid crisis, the organs were coming from the accidental deaths on the road. People were healthy, they accidentally died, and they were brought to the hospital and they transplanted organs. So I met a gentleman in Toledo, Ohio. He runs a kidney foundation, and he had a kidney transplant himself at a young age. And so he's trying to help others. And so he and I had a discussion a couple of years ago, last year, in fact. And he said, when COVID happened, we were worried that we wouldn't be able to get that many organs, but the death rate went up. And some places and hospitals, you can get an organ transplant, kidney, like next week. Other states, there may be longer wait, depending upon, the availability and stuff. But it's become much easier. That's the real business behind it.
Mm-hmm. And so with substance abuse, I guess there's complications with that, but are they able to use medications and to make sure, I mean, at some point the liver goes bad over a certain, I mean, what's that factor too with substance abuse?
No, so substance abuse is more of a mental problem. The liver will go bad if they're drinking too much or they have hepatitis C. Okay. The heroin, the cocaine, the OxyContins are not going to cause liver damage unless you have too much of acetaminophen in there, the Tylenol. So the newer pills are pure oxycodones and stuff. So there is not that issue. So liver is not an issue in most cases.
And so that's the number one harvest organ is liver then in the
No,
transplant.
when somebody dies, they take the heart, the liver, and both the
Okay.
kidneys.
Okay,
All
gotcha.
4 organs, major organs,
Wow,
plus skin, plus eyes, cornea and stuff. Yes.
man. That's anyway. I don't. Where do we go from there? Jeez.
So there is. Let's talk about a study that happened in the state of Vermont about a decade ago. It's called Vermont Model, and the American Medical Society, after the study of 4 years, said it's very comprehensive. And one thing they said is the medication assisted treatment is a gold standard in treating and saving lives from addiction. And the assistant surgeon general, for the first time, I think his name is Brett something, said 2 years ago for the first time that we should promote that, but that's not being promoted. What is in that model? In the middle, there's this hub where there's a nurse, a doctor, addiction doctor, and the 8 spokes on the side for all the psychosocial problems that these people encounter. So it's very comprehensive. It's very expensive. On a Medicaid fee schedule, is twice as more expensive than any other insurance could afford, so it's not being duplicated. So if you go back and look at the country of Portugal, 10 million people, and they in 2008 felt that they have this crisis. And so what did they do? They created a central agency and they said, we're going to treat addiction like any other disease, a chronic disease, for long term. And they felt treatment was not enough. And they felt these patients were demotivated to do anything. They just wanted to lay low. So they created programs to reverse their demotivation. Then they rehabilitated it. Then they educated them. They put them into job training and job placement. Everybody is in treatment, what I'm talking about. And now, after 15 years, they have 90% of the budget in treatment and social programs and only 10% in law enforcement. We have it the other way around.
Mm-hmm.
We do spend a lot of money on social programs, but they're not effective. So if you look at supplying clean needles and heroin, a lot of communities are doing that on compassionate basis because people are demanding, they don't have access to doctors, they don't have access to treatment. So studies came out of Vancouver, Canada 3 years ago and Portland 2 years ago. It said these providing clean needles and heroin failed in all 5 categories. The addiction rate went up, the death rates went up, hepatitis B went up, hepatitis C went up, and HIV went up. So nobody gained. Now, Vancouver, Canada, last year, approved 2.5 grams of fentanyl, which is 1,215 lethal dosages, to be legal possession by these addicts. Because the government has so much fentanyl, people want to experience the next high. And so that is being demanded now in America, and the death rates will keep on going up. It's only 2 milligrams of fentanyl that's a lethal dose. And that sits on the tip of a pen.
I really appreciate you taking, sharing with the Vermont that we have information here in America that the efficacy that works. It's just a little problem with the cost, the lack of long-term, leadership, and then also Portugal, that you really shared what I think is the most important thing that anyone can say is purpose, having a purpose in life, whether through job. Of course, we know a lot about trauma. A lot of this is traumatically, and when you have trauma, you're more susceptible. Also, there's those cases where someone has pain, back pain or whatever, anecdotally. I know you know way more than me as a doctor, clinician, but can you share a little more about the power of peer support groups? We know that like AA has been so instrumental. It's still around as part of those spokes that you mentioned. I'd love for you to share a little bit about what Portugal and Vermont about that.
So The AA has been around here in this country for over 100 years. And the success rate consistently over the 100 years, if you just go to AA, is 12%. That means 88 people will fail just doing AA. And I'm telling you, 85% will live and do well if they are in treatment. I'm not saying anything is wrong with AA, but that model was necessary, but nothing else was available.
Mhm.
Now we have an effective medicine available for opioid crisis for the past 22 years. We don't have the doctors. We don't have the path to give them the medications. And then they criminalize the treatment arm, put limits, regulations, and oversight, and that makes it more difficult. So instead of enticing doctors into learning and practicing addiction medicine, they create a problem. So any profession could be addicted, get treated, and be back to work. Doctors cannot be addicted, cannot be treated, and cannot be back to work. Okay, and then 1,000 doctors have been shut down. So what happens? The others pay attention and say, we don't want to get into this mess. I don't want to become homeless and government take away everything and I go to jail and what for? So those are the kind of problems facing. Then there is, your question was more towards the other social programs, peer recovery coaches. So there's a doctor, there are licensed counselors who go to college for 4 to 8 years to become counselors. And these peer recovery coaches are essential in the beginning when you have a new homeless, addicted person that has no resources, no car, no place to sleep. So these people can coach them. I've had a few years ago in my office, and they would make phone calls and get them a car and get them a place to sleep, get them food and the stuff. But the insurances don't want to pay for that layer of care because it's not treating anything. So the counselors, the certified counselors, come into the way and lobby that, hey, because they're afraid if government and insurances keep paying for the peer recovery coaches, then they're not going to get paid. They're going to lose their shirt. Mm-hmm. So, but my experience of 18 years, my patients are doing very well. They don't even go to counseling. They don't need peer recovery coaches.
Yeah, I think it's a lot like the moment we had in psychiatry when they started getting psychotropics to help with schizophrenia. I imagine it's a similar level of the efficacy at some point. I know there's still problems with, some of these SSRIs or whatever antidepressants. It's still not perfect for everyone with treatment, but it sounds like the evidence is there over the 22 years. I don't know if it's just in the science that you're practicing as addictive medicine. You have the substitutes or whatever it is to help those people alleviate those addictions and function really well. I'm curious, we have a ton of doctors, or unfortunately, doctors are trained at academic medicine places, and most of them are incentivized to be specialists because of the economics there. Also, because they're studied there, they're not really encouraging, internists or family practice medicine. What is the actual problem? Also, is there just a lack of reimbursement to the 275? I imagine if all of a sudden you got paid $50,000, like let's say $1 million more, whatever revenue for that 275, even though the ROI could be it's unforeseeable, the amount of ER visits and all the different costs, ROI savings, ROI. So what is do you think that is it more that the physicians are worried about the regulatory, like losing their license, getting involved in this addictive medicine, or is there just not enough compensation per patient for the practice of it?
So I don't do any surgeries. I'm going to give you a roundabout answer. You do not want me to open your belly, take your appendix or your gallbladder out. These people are very, very complicated and they're very lethal condition. So doctors need more and more training to tackle this stuff. There is no training, I'm telling you, in American medical school or any medical school on a consistent basis to learn and teach addiction and practice addiction. There is no incentive created by the government to do that. So let's say you're a healthy 65-year-old male who has got a little bit of sugar problem, blood pressure problem, cholesterol problem. System requires that we see you every 3 months and one visit for annual wellness visit. Once or twice a year, you have a cold or something else goes wrong. So an average patient is seen elderly patient, about 6 to 8 times in a year. The addicted patients are very, very complicated. Mental issues, addiction issues, other complications that have happened in their lifestyle. And in the beginning, they have to be seen once a week till they're stable over the next 4 weeks, and then 2 weeks and 3 weeks, and once a month forever. So these patients have to be seen about 30 times in a year. So if you look at the computer graphs, and I have 275 patients, and the insurance says, this guy's doing something goofy. He's all in fraud, abuse, or waste. So there's a lot of audits happening again and again and again. And that creates a problem. Should I be spending time and effort in providing the audits or take care of the patients? So there is no thank you. There is no chocolates or flowers sent to me by the insurance companies. And it's just a headache. And they're in the way of not letting us do our job.
And so basically, if I'm able to understand, are you saying just about there's the same reimbursement to whether you're taking care of a 65 plus chronic care with, whether it be high blood pressure, diabetes, as it is to someone with, that you're doing once a week with addictive medicine right now? Is it the same reimbursement to a doctor?
Yeah. So it's not only that. Because of the frequent visits, they want us to down code the bill from 99214 to 99213, which is 40% less reimbursement. Half of my patients are on Medicaid, and that pays 30% less anyhow. Mm-hmm. So it's not only lack of incentive, there's a lot of disincentive.
Yeah.
Even in reimbursement and audits.
So when I hear this, it is just hard to believe that there's no common sense out there, that you're not being heard, that there's not other doctors, there's not irate family, the moms, the children. It just seems like there's just so much lack of information. If someone would hear this, like, something needs to be done.
So, I started speaking more than a decade ago, 5 years ago. I was getting frustrated. And I said, no one is talking about this crisis. Nobody's asking questions. Nobody is visibly upset, parading in the streets or doing demonstrations. Like when 40 years ago, 45 years ago, when HIV and AIDS crisis happened, people were demanding answers. Okay. And I said, the media is silent. To me, it felt like the crisis is on a different planet, and we need to be responsible and wake up and do something. I used to have that slide, 5 years ago. But like we're talking now on podcast, I've done over 1,000 presentations, and I don't charge for it. And so now we're talking. I mean, I spoke to a group of financial people. I spoke to the health department. I'm going to talk to, in 2 days, to AMA president-elect, one-to-one, face-to-face, is coming to our town in Detroit to speak at one of the Rotary meetings. So I was told he's coming. So he's read my book, though, 2 years ago.
Who is this?
This AMA president-elect.
Okay, cool. So the current AMA president.
Elect for next year.
Oh, okay. Okay, cool.
Okay. His name is Dr. Bobby, and he's an ENT surgeon. And he read my book 2 years ago. So I wrote everything that is possibly wrong. And I think AMA has some share of it to be blamed, like we heard in the Purdue story. And he probably read that and he never called me back. But I have a book ready, his name written on it. I'm going to hand deliver it in 2 days. And ask him questions about what is his plan to fix it, and go from there. So I'm trying to reach out to different policymakers. Our Surgeon General has my book. The lady who wrote the story on Purdue first time came out as dope sick, Beth Macy. She and I are on a national platform. She has read my book. She has my book. So I'm trying to reach out, different senators, congressmen, and different, but nothing is happening because they don't have the right information. In fact, I tell people there is no good information out, and so they just mishandle the bad information, repackage it, and then they just disseminate the wrong information. So information has to be accurate. Unfortunately, the media and the policymakers do not have it.
Yeah.
That's
what about versus Biden and Trump? It seems like they've really both managed to not tackle the real deal on this stuff. I mean, is there any discussion for any of those two platforms about this?
So when Trump came into got elected, we were noticing 8 years ago, 10 years ago, that fentanyl would show up in the drug test. And we thought, as medical community, the fentanyl that I write as a patch for pain control, or the surgeons use in the hospital setting for surgery, was the source of this fentanyl on the street. Usually when new crises happen, the researchers and government takes about 3 to 4 years to figure it out. And they figure out it's coming from China. So Trump administration put pressure and stopped that. Local pharmaceutical businesses cannot import that precursor and then manufacture and repackage and sell it. So then administration changed and the borders opened, and then it's coming freely. So our friends in the media and in the similar business, recovery coaches and halfway houses and stuff, and they tell me that 10% of the cars that cross the border in San Diego are randomly checked for drugs. 1 million cars cross in a month, so the drug dealers know that. So if 90% of the cars are crossing, there's enough fentanyl coming. And so that is the difference. And now it has become such a problem. Both sides are wanting to talk about it. Mm-hmm. But in the meantime, we've lost 1.2 million people in America, probably a lot more. 1.2 million from drug overdose are documented. The problem occurs if you quit breathing at the scene and the EMS comes and puts a tube into your throat and puts you on a breathing machine. Then the cause of death becomes a respiratory failure with ventilatory support. So the bill goes from $1,500 a year visit to $16,000. So then the death is labeled because of that reason. If you're having electricity problems in the heart, they're gonna label as cardiac arrhythmia, not drug overdose. So the number of deaths are much more than what the government has recorded.
So wait, help me out on that too. Is there financial incentive to track drug overdoses or something else?
No. So 15 years ago, if I would go to the emergency room and see my patients, I say, I want a drug test done. The ER doctor would fight with me and say, we don't want to do it. Why do you want to do it? And I said, this is the reason I want to do it. He says, but we're not going to get paid by the insurance company if we run a drug test. So that was the status 15, 20 years ago. Because we don't have the resources of follow-up, they're still just being brushed under the rug. And so I had a case 8, 9 years ago. One 25-year-old guy come to the emergency room with overdose, and he was revived and sent home. He walked out of the emergency room, did not follow with anybody. Next week, I was on call, my call for the emergency room, and the same guy comes there. He's brain dead. He's admitted to ICU, and then we called the neurologist and the lung guy, wean him off the machines, and the family is being approached for organ harvesting. So the family is upset about, he was fine last week, and how could he die? And then you wanted the organs. So that's the situation, which is, not being talked about.
Yeah. So tell me about the age of your practice, kind of your 275, just if you could. I know no violation of HIPAA. I mean, we're not using
No. There is no HIPAA issue. So, addiction was primarily a problem between the ages of 18 to 56. That's the most difficult age. But in the last 2, 3 years, when pills are being pressed in Mexico and come here, we're noticing about 2 dozen teenagers in a week dying from accidental drug overdose. They were never addicted. They took a pill, somebody gave it to them for pain or anxiety, whatever. So that's created a new level of problem now.
Okay, so you're seeing we're talking under 18. We're talking
Under
maybe
18, 12 to 18, yes.
wow.
Two dozen, 2 dozen young teenagers are dying a week.
Mm. So
And
this
we
is
have
sorry.
and we have 300 to 400 people die every day. That's like one jumbo jet coming down every day, and we don't want to do anything. You know, my other situation is look at your father, my father, and other 85, 90-year-old patients. We want to do everything to save these people when they've lived a very good life and they're at the end. But we don't want to do anything to save the lives of these 20, 30-year-olds. Why?
Yeah, I look forward to reading your book. I have gotten in the habit of not necessarily reading every book, or sometimes with guests, but I'm telling you, you are so well informed. I mean, it's because nowadays anyone can write a book, Dr. Gupta. You know that, right? With Amazon and then Chat GPT. Gosh, how many people
Yeah.
are writing?
Yeah.
But this is something I hope you can get elevated. You should be on all the networks. Not that but to me, the amount of knowledge and insight to this situation. And I'm not the smartest person. I've done this because just like I love learning. This is how I learn, by doing these. And so what you've clearly articulated on just the time we've had, 40 some minutes, is a solution. What it's and it's like I don't want to say conspiratory, but when you're looking at hundreds of thousands of dollars ready sourced, all the organs you could imagine, up to millions, I guess, when you add them all up per individual, it's frightening. And this is the first I've ever heard of that. But then also the BS that you have to go through as a doctor to be in fear of audit, and the lack of reimbursement, where the common sense is, if they just would make through Medicaid, just say, all right, let's let all these doctors get trained, or a value-based state by state or county by county initiative. Let's get a block grant for Dr. Gupta to treat this amount of patients, maybe 10x it. You could do 1,000 patients. I mean, those are the sort of things that could be discussed by county, mayor by mayor. So, whether it be through a federally qualified health center, it's just like, let's do it. Let's try something.
Have you heard of implicit bias trainings?
A little bit, but not assigned.
As physicians, I have attended in the last 3, 4 years during COVID, and even now, about 50 of them. And it doesn't make any sense to me as a physician. I don't have issues with my patients in my practice, but we just will get an invitation. Nobody wants to talk about doctor problem, patient problem, like stigma. So one speaker, I said, hey, your slides are getting very fancy on this implicit bias. Are you able to do it yourself, or somebody's providing it to you? And she felt offensive because she's a paid speaker. And so I said, well, how about talk about the issues that matter to us, but nobody wants to do it. So, when I go to, I attend a lot of meetings online and national platforms. So there's group to how to reduce stigma, and everybody says, let's reduce stigma. I said, guys, you got to do something. You cannot just say, like, I'm stepping out of the house, it's raining, I've opened my umbrella, and I'm not going to get wet. To reduce stigma, you got to do something serious. And I have proposed mandatory education for everybody, policymakers, medical professionals, insurance companies, on at least 4 topics. addiction, better vocabulary, empathy, and humanity. And unless that information is created and disseminated to everybody, the stigma is not going away.
Yeah, I've had a conversation with someone who was very educated, and I almost feel like it's like these crazy reefer madness, all the just bizarre stuff, like out of the person's mouth was basically that it's a deviant behavior. I mean, still for 10% of the population that unfortunately gets hooked, it's like genetic. I mean, that is to me, and that was an educated, successful person. And when I was talking about the opiate crisis, and that's how they wanted to quickly label it as not my problem. And I could not believe someone would say that.
So, over the years, people would ask me, Doc, are there any regulations that affect this problem? So I did more research and I found there's a Harrison Narcotic Tax Act of 1914. The American government was trying to control the trade of illegal drugs around the world, and they put a tax on it. Medically, it said addiction is a moral failing and is not treatable. Even though the Supreme Court overruled in 1962, nothing has been done to otherwise in the last 60 years. The second thing is said, a doctor cannot write another addictive drug for an addictive condition. So methadone has been around for nearly 60 years. We doctors are not allowed to write methadone for addiction. I can write methadone for pain, but I have to specify it as for pain, and it's much lower dose. The second medicine that came out 22 years called buprenorphine or Suboxone, and that's because if they made it class 3 drug. Methadone was 2, is more stronger. Suboxone is class 3. The federal government and DEA debated for 30 years what should be the class of that drug. Had they made that drug a commodity like for diabetes and hypertension that any doctor could write, we wouldn't have this problem. Now, as of last year, they're trying to do the same thing. All the state and federal regulations are still in place, but they're saying any doctor could write it. So if I've never done surgery, nobody wants me to open their brain or their chest to fix their problem. So doctors need more training and not less. And those are the kind of things that we're facing in this situation.
Well, after this conversation, I hope you can share more links. I'll definitely put your book. I do a newsletter, and so if there's any bit of resources in addition to your book, what I do is I post this podcast, and then I'll do a follow-up on the newsletter where it's on my actual website with the most appropriate links, resources. And I'd hope we can get you on again if we can have more people, more speaking, more. This to me is just a starting point. I feel I can't be a citizen of the United States nor a human being in this global world without wanting to be doing something about it. I think there's certain things that just we all need to be engaged. We're talking about so many AI and all this stuff, but if we can't take care of our humans and suffering when we have common sense, we got a real big problem. So I just cannot help but want to help in some case. And then also the other thing that I think is really problematic, and I'm just putting out there, is the 232. I feel that it's so problem that we have technology and social media that's so powerful that is doing mental health harm. And I know there's a connection between mental health and addiction, substance abuse. I don't want to open up another worm. We have a few minutes left, but it troubles me as a parent of 14 years old, a daughter who's 14, a female. Of course, that's a daughter. Excuse me. That doesn't make any sense. But we at this point, she's just now started her social media Instagram account because we didn't want her to be ostracized or left out. That's how girls communicate. That's how they connect with friends. But I do think the Surgeon General trying to do a label could be good. But I think it's really unfortunate that we have an industry that's so powerful, like 100x more powerful than previous cigarettes and tobacco, that is able to just get away with all freedom when they know they're doing harm. And I'll stop there. If you have any thoughts to that and how that is part of this too.
Well, so I see social media people get in a lot of trouble, both very younger people and others. It's a dangerous platform. I do not like it. I use LinkedIn only. The Surgeon General warning came out at a good time. Should come 5-10 years ago. Yes, we need to put more bells and whistles and screws and tighten the news. Like TikTok has been a bad news. Nothing has been completely done. Snapchat, people can order drugs of any kind. The kids can get these drugs delivered at home. Two things about myself. I do have an audio book. It's 9 hours long for you and for busy people who don't have time to sit down and read. The $1.25 I get, I don't put in my pocket. It goes to a foundation. I have a 501c3 foundation. I'll give you the information. And I'm trying to raise some funding so that I can keep on work for the people and save America from within. So I will give you those links. I don't have any personal problems in my life. I'm thankful. The country has been nice to me. I have 3 kids. They're all doctors and they're doing well. And this is my way of giving back to the community and to the society. And our culture says, you do your stuff, don't worry about the rewards. And I was getting a little bit troubled that nothing is happening after my book came out. And then I talked to some of my academic friends and they said, Doc, the cause and effect relationship takes a lifetime sometimes, which means I may not see the effect in 20 to 30 years. But by that time, we may lose millions and millions more because the death rates are going up 30-40% in the last 2-3 years. So we need to fix this problem sooner than later. And that was the reason that I wanted to come on your platform, because I see you have some powerful people on your platform that you connect with. And I said, okay, I would try to reach out. And I'm thankful that you responded immediately and I could rearrange my schedule, even though I told you my schedule was pretty hectic. I'm going to New York and Connecticut in a couple of days and then be back in 10 days. Then I have to go to North Carolina to do a presentation and that kind of stuff. And so I really appreciate, Mike, you took the time. And I think we could have a better, wider discussion after you listened or heard my book. And I'm really appreciative.
No, absolutely. I'm so glad you came on, Dr. Gupta, and this has been so informative. I mean, that's what I'm trying to do, is get some good information out there, and it's from people like you. And so you've been working a lifetime on it. So I hope we can have you back on in the future. I will post your book so people can get that, and I'll actually, I'm very motivated to read it and get it. So anyway, I really appreciate it. Until next time, friends and fans, I hope you've enjoyed this.